Everyone, and welcome. My name is Katie Sacra, and I'm the Director of Family and Community Engagement here at the GFPD. I'll be moderating today's webinar alongside Ryan Maple, our Executive Director here at the GFPD. We're so glad that you're able to join us for tonight's event, Navigating Neurology and Peroxisomal Disorders, Part 1 of this two-part webinar series. We are so grateful to have Dr. Isha Srivastava here with us today. She is a dedicated physician scientist at Stanford University School of Medicine within the Department of Neurology. She completed her undergraduate studies at Johns Hopkins University, followed by her MD and PhD at Temple University and residency in child neurology at Stanford. Her research is focused on exploring the nexus of lipid dysfunction, neuroinflammation, and peroxisomal disorders. She is developing innovative cellular models to investigate how lipid overload affects immune cell function and contributes to disease pathology. Her work aims to uncover therapeutic pathways that can be targeted to address lipid dysfunction and neuroinflammation in these disorders. Clinically, Dr. Srivastava specializes in pediatric leukodystrophies, particularly peroxisomal disorders, as well as pediatric acquired white matter injury. She is the Associate Director of the Leukodystrophy Clinic at Stanford Children's Health, which has been designated a Center of Excellence by the Leukodystrophy Care Network. Through her clinical care and translational research, she is committed to advancing the understanding and treatment of pediatric leukodystrophies and peroxisomal disorders. She also serves on the Medical and Scientific Advisory Board for the Global Foundation for Peroxisomal Disorders. After her presentation, she's going to take the time to answer all of the questions that you have. So you're encouraged to submit questions at any point using the Q&A button or the chat box throughout the webinar. Dr. Srivastava, thank you so much for being with us, and I'm going to now turn it over to you.
Thank you, Katie, for that awesome introduction and setting me up for our talk today. I am really excited to talk with all of you about the neurological symptoms in peroxisomal disorders. And as a quick outline of the talk, so that we're all on the same page, I'll be reviewing very briefly the role of peroxisomes and the role of the nervous system, reviewing what I mean when I say the nervous system, and hopefully getting some input from all of us here today about the neurological symptoms that can occur in peroxisomal biogenesis disorder and Zellweger spectrum disorders. And then reviewing the role of the neurologist, including neurological monitoring and testing and what that can look like. And then a good chunk of the talk will really be talking and focusing on seizures and epilepsy, including their diagnosis, management, and seizure safety. I'll share some resources, and then, as Katie mentioned, we'll have a section at the end and time for Q&A. And so with that, I'll go ahead and get started. So peroxisomes are a specialized processing factory within the cell. So in this schematic here, you can see a cell with all the different components, and peroxisomes are one organelle or one part of the cell. And what they process are actually lipids. So they're responsible for breaking down these lipids, and in that process, they can also take care and detoxify products like hydrogen peroxide that are produced during this metabolic process. Critically, they make really important lipid-based molecules, including plasmalogens, bile acids, and cholesterol that play really important functions throughout the body, including the brain and the nervous system. And you can imagine that this lipid processing factory, also known as the peroxisomes, are really important for the brain to develop typically, as well as for the formation and development of that insulation around the nerves called myelin, as well as the detoxification that I talked about before. So you can imagine when this factory isn't processing lipids properly, or there isn't enough of the peroxisomes or enough factory members present, it can affect the nervous system and result in a variety of different neurological symptoms. Now, I've said the nervous system a couple of times, and I want to make sure that we're all on the same page about what is the nervous system. And so here I have a schematic that includes the brain and the spinal cord. Sometimes these two parts of the nervous system are considered the central nervous system. Also on this schematic are these light blue nerves that connect the brain and the spinal cord to different parts of the body, including different muscles of the body as well as different organs. So, as you can see, the nervous system controls a lot and processes a lot of signals that go from the brain to different parts of the body. It ultimately controls how a person thinks and learns, but also how a person can respond and move to different cues in the environment, as well as regulate key body functions. So it does a lot. And so I want to hear from all of you in terms of what are some of the neurological symptoms or challenges that you or your loved ones or your child may have faced. And to do this, we are going to do a poll everywhere link. And so I apologize, it doesn't look like this is showing up, but I can put the poll everywhere link in the chat. And all you have to do is click on the link to tell me and answer the question that I've posed there. So here is the link, and or you can post it in the chat, and Katie and Ryan will help me look at it as well. And so the question, as I mentioned, is what neurological symptoms or neurological challenges have you or your child or your family member faced? We'll take a minute to gather some of that information and input from everyone that has joined us today.
We have one in the chat, neuropathy.
Great. I also see that here.
And just to our audience, you can share it just with the host and panelists as well if you didn't want to share it through the chat for everyone. So if you submit that through, we can all see that on our end. Epilepsies, ataxia, bowel and bladder dysfunction.
Yeah, all really important symptoms and very common. I see epilepsy showing up on the word cloud, ataxia, neuropathy.
Low muscle tone.
Yeah, great. Low muscle tone, ADHD, nystagmus, bowel and bladder, 100%. So I compiled a list of some common neurological symptoms, and many of you put these in the chat, and they showed up on the word cloud. So seizures or epilepsy, low tone or hypotonia, neuropathy was also there, ataxia or difficulty with coordination, some cognitive differences. I also saw ADHD and behavioral changes that are here. And so, what I wanted to highlight with this exercise, and I apologize that the poll everywhere didn't work as smoothly, so I appreciate all of you working with me, is that the neurological symptoms, one can have a lot of different ways, and that they appear in people with peroxisomal disorders. And that's because, as I hopefully showed you earlier, the nervous system interacts with lots of different parts of the body. And so the neurological symptoms that can show, that can be present, can affect the body in a lot of different ways. And your responses really highlighted that. It wasn't one part of the body, it wasn't just seizures, it involved a lot of different parts of the body that can be affected. And as I'm sure many of you have experienced or seen, these symptoms can be really debilitating and they can really affect your day-to-day life. And so, from the voice of the patient report, from feedback from many of you, neurological symptoms, including changes in mobility, orthopedic symptoms, balance issues or ataxia, motor delays, were consistently the top three symptoms that were included. And so, I want to talk a little bit about how these neurological symptoms um, can be thought of from a neurological or neurologist's perspective. And so, one thing I want to hopefully emphasize is that um, the nervous system, like many other parts of the body, is really changing and growing. And so, when you think about the brain, spinal cord, nerves in a little infant here compared to someone that's going to school, for example, someone that's 5 years old, the nervous system and the brain and the spinal cord and the nerves and the body has changed a lot. And so, what this means is that neurological symptoms and how they affect the body can change over time. For example, low tone when a child or an individual is a baby can affect how they hold their head or how they move their arms and legs. When you're a little bit older, it can affect how you sit if you're able to sit, and how your arms and legs move, and how you reach for things, and what kind of support you need to move. And so, neurological symptoms can change over time and how they present themselves. And for that, it's really important that these neurological symptoms are monitored over a lifespan, not just at snapshots through at one age or not at another age. So, how can your neurologist help? They can do quite a few things. One is evaluating and monitoring both symptoms that patients have, but also monitoring for new symptoms that might appear later in life. And some of the ways that they monitor this is through imaging, and we'll talk a little bit about what are the different imaging types, neurodiagnostic testing. And again, in a couple of slides, I have some more information about what I mean about these tests and what these tests are measuring. And also, very importantly, a neurological exam to look at how the brain, spinal cord, muscles, and nerves are functioning. They can also help medication management as well as treatment options for managing many of these symptoms. And then they can also help coordinate care with specialists, both within neurology as well as outside of neurology. So, as some of you may know, and maybe some of you are less familiar with, neurologists can also have subspecializations within neurology. And so, it's not uncommon for a patient that is medically complex, like many of our paroxysmal patients, they may end up seeing more than one neurologist. And each neurologist specializes in a different aspect of neurology. For example, they may end up seeing an epileptologist or a neurologist that specializes in seizure management and seizure treatment options. And they also may see a neurologist that helps manage the low tone or spasticity or increased tone. And I think most importantly, your neurologist can really partner with you to make sure that your concerns are being heard throughout your care team. Over the next couple of slides, as promised, I want to talk a little bit about the neuroimaging and the neurodiagnostic testing that I talked about. The two most common neuroimaging modalities are CT, and I'll focus on the CT of the brain, and MRI brain. And down here are two examples of what these pictures of the brain may look like. As many of you may know, CT is based on a series of X-rays. So they use radiation. They are very, very fast, 5 to 10 minutes, and you get a picture like this of the brain. And they're ideal for imaging where we need quick snapshots of the brain, ideal in emergencies to look for big changes in the brain. The MRI does not use radiation. It is a magnet-based imaging modality. And you can imagine that magnets and metals may or may not be compatible. It usually is a much slower acquisition of the picture, so it can take up to 45 minutes, sometimes even longer. And because it takes longer, some children and adults may need some sedation or some medication to help them lie still for that long of time. However, it does provide a very detailed view of the brain. And so if you look at this picture, you can see the dark areas of the brain or the gray matter, the white areas of the brain, that's the white matter, and it's really easy to tell that distinction in this image. It's possible to tell that distinction on this image, the CT image, but it's a little bit more tricky. It's a lot more subtle, and it takes a trained eye. And as I mentioned, that MRIs are compatible with, I wrote some, but it's probably most implanted devices, but definitely not all implanted devices. So sometimes you're not able to get an MRI. Um, but what I do want to emphasize is this neuroimaging is just that. It's giving us a picture of the brain. It's not telling us how the brain is functioning, and it's not really able to predict what future changes may look like. It's just giving us an image or a snapshot of the brain at a specific time. Next, as promised, we'll talk about the neurodiagnostic testing. And so the first test I want to talk about is the EEG, which is used to evaluate brain waves. And here is a schematic that shows a young adult with stickers on their head. Those are the EEG leads. And this is what the readout is of the brain waves. And so there's a couple of different ways that neurologists like to use EEGs. One is to evaluate the background, so the brain waves just when the patient is awake, asleep, with or without the presence of seizures. And this is to determine, are there areas at risk for seizures? The analogy that I often tell my patients is if you think about seizures as fires in the brain, then this test or this background is looking, are there areas of the brain that have sparks? Now, all of us, with of us that have seizures, those of us that don't have seizures, all of us can have a few sparks here and there. But when we get worried is when we see a lot of sparks or a lot of eleptiform activity. And so, another use of the EEG is if there are seizures, it can help tell us how often the seizures are happening, how many seizures are happening, but it can also tell how often these sparks are happening and how many different parts of the brain are having these sparks. And lastly, it can also help determine if a specific movement is a seizure or not. So I hope this is highlighting that EEGs are doing a lot more than just is there a seizure or is there not a seizure, and can tell quite a bit of information even in the absence of seizures happening at the time of the EEG. The other test that I want to talk about is called a nerve conduction study. And it's really trying to figure out are the signals that are coming from the brain, the spinal cord, how well are those signals reaching the muscles? And so this is a schematic of what the nerve conduction study can look like. And it's essentially checking, similar to checking the wiring in the house. Is the electricity getting to the socket? Is the electricity getting to the light switch? And is the light switch working? So oftentimes the nerve conduction studies are combined with EMG, which helps tell us, are the muscles responding as they should to the signals from the nerves? And with that, we're going to shift gears a little bit from talking about some of the neurological imaging and testing to really focusing on seizures today. And so the rest of the conversation will be focused on seizures. And so, as many of you know and maybe have experienced, seizures are quite frequent and quite common in patients with peroxisomal disorders. And one of the studies from MOSME showed that the combined prevalence of seizures in all individuals with ZSD is up to 53%. That's about half the children and adults with Zellweger spectrum disorders having seizures. And so with that, I want to focus on really understanding what do we mean when we say a seizure. And so a seizure is really, like I said, that electrical disturbance in the brain that can interfere with normal function. Many of you may have also heard the word epilepsy. I remember somebody put it in the chat. And so epilepsy is really the condition that means that you're at increased risk for having seizures. And so I really like this quote that I put down here from one of our epileptologists over at Stanford, that seizure is the event and epilepsy is the condition. And oftentimes they can be used interchangeably, but to your neurologist, they mean slightly different things. Epilepsy is diagnosed in a couple of different ways. It can be diagnosed based on the presence and frequency of clinical seizures, as well as based on those EEG findings that I mentioned earlier. So if the EEG findings show that you have an increased risk of seizures, then you'll be diagnosed with epilepsy. Sometimes the pattern of the types of seizures and the types of EEG findings you have can be associated with a specific epilepsy syndrome. And lastly, I want to spend just a little bit of time talking about status epilepticus. Many of you may have also heard this word or these words, and this means a prolonged seizure. Typically, it's defined as a seizure greater than 5 minutes, so a single seizure that's greater than 5 minutes, or back-to-back seizures without return to baseline. And this is one of the things that we're trying to limit or avoid. And so, I want to emphasize that not all seizures are the same, and not all movements are seizures. And so there are lots of different types of seizures. I've listed some types of seizures that can be seen, peroxisomal disorders. It's a lot of words, but what I want you all to take away is that seizures can look very different and they're not all whole body shaking. So there can be focal seizures, which really come from one part of the brain. And those can be limb jerking just in one limb. They can be as subtle as just the eyes churning. They can be lip smacking or other facial movements. And they may not involve the whole body. I think this type of seizure, the whole body seizure, is what many people think of when they think of seizures. And this is what we typically consider a generalized seizure. So it involves multiple parts of the brain. There can also be infantile spasms. This is one of the types of epilepsy syndromes that I had mentioned before. And some other types of seizures as well, including brief muscle twitching or jerks called myoclonic seizures, drop attacks or atonic seizures, and sometimes seizures can be very subtle without clear movements. And so as you can see, seizures have a lot of different ways that they can present. But as I mentioned, not all movements are seizures. So if you see a movement and someone tells you it's not a seizure, what could it be? These are some of the different categories or different examples of movements that can sometimes be confused for seizures, but are not seizures. And a couple that I want to draw your attention to include reflux or something called Sanderford syndrome, which is when you have reflux and you make this back arching movement, which can often be confused for a seizure. Tremors, which can involve one or multiple parts of the body. Dystonia or involuntary muscle contractions, where your arms or legs may get stuck in a position, can be sometimes confused for seizures. So, what I want to talk about next is the key stages of a seizure. And so, this is maybe definitely how I think of seizures, or honestly, any abnormal or new movement. But chances are this is also how your neurologist thinks about new movements. And so the stages to think about is before the seizure or movement or episode happens, what was happening at that time? What was the episode, seizure, movement of concern? So, what was happening during? And then what was happening after? And so, some questions to think about in each of these stages are in the before, um, was there any warning that this was going to happen? Sometimes many of my patients and parents will say, the patient just looked different. I can't pinpoint what, but I knew something was wrong. And that's important to share that something was different. They look scared, they look pale. Also, I say child here because I'm a child neurologist, but it involves any individual. So what were they doing before the seizure happened? Were they awake? Were they sleeping? Were they walking around? Were they talking? And then are there any triggers that could have brought on this episode? These triggers can be environmental, a loud sound, a loud light, or a bright light, but they can also be triggers that might be things like they didn't get enough sleep, they had a cold, a cough, a fever, they missed some medications, they were very stressed, or there was a really stressful time. All of those are important to take into account. In the stage of during the seizure, it's important to see where did the movement start if you can, and what did the movement look like. And I have a special asterisk to what did the movement look like that I will say it's important for you to use words to describe the movement, but sometimes it can also be helpful to just show what the movement looked like. Because sometimes when my patients say, for example, tremors, it means something very different in my head and in my understanding than it does with what they've seen. So sometimes it can be really helpful to just record the episode if you can. This recording does two things. One, your neurologist or other provider is able to see exactly what you saw, but also it can help time the episode, even if you start the recording halfway through, which is this last bullet point. The other things to think about is, was there any color change? Did they become pale? Did they become dusky around the mouth or in their hands? And were they able to talk, or were they completely unresponsive? And so some ways to develop to test responsiveness is by calling their name. Did they turn or respond when their name was called? That's called vocal stimulation. Or when you gently touch the part of their body that was moving or touch their feet, did they respond or change their movement? And then in a seizure, when the movement or the shaking or the episode of concern is over, how was the child, again, I say child, but any individual, how were they feeling? Were they back to baseline immediately, or did they appear tired and take some time to get back to baseline? Was any part of their body looking weak, or did one part or one side of their body take time to recover? These are the types of questions that your neurologist is probably thinking about. And so, if you're able to provide any of this history when there's a new movement, a new seizure type, it can be very helpful. I wanted to take the next couple of slides to just review briefly seizure first aid. So, what to do when when you see a seizure or when you see someone that's seizing. One is make sure that they're in a safe spot. If they're in a chair, it may be better to put them gently on the ground if it's possible. If they're on the floor, sometimes it can be helpful to put something soft under their head, as shown here. It can be helpful to put them on their side to prevent any choking. If they have any tight jacket or scarves or anything tight around their neck, it can be helpful to loosen it to prevent any sort of tightness or strangulation around their neck. And then, like I said, really important to keep track of how long the seizure lasts or begin recording a video. Some things not to do is not to try to hold the child down. to stop the movements or stop any tongue biting that might happen. And don't put anything in their mouth or try to open their mouth. Most seizures will stop on their own after, anytime between 30 seconds to a minute or so. I wanted to put this here as well as when to call 911. Anytime it's a first seizure, if the seizure is lasting more than 5 minutes, if they have back-to-back seizures, if you feel like the person is having trouble breathing or they have any injury during the seizure. And I always tell my families that if there's something that you're worried about, call 911. Now we're going to switch gears a little bit and talk about treatment options for seizures. So one treatment option is called a rescue medication or an abortive medication. And this, as I mentioned before, is to prevent seizures from becoming status epilepticus or preventing really long seizures. So typically, these rescue medications are given when seizures are longer than 5 minutes or back-to-back seizures. The medications include both a rectal medication as well as nasal medications because during seizures, individuals often are not able to take things by mouth. The most common side effects is that it can slow down breathing and make individuals really sleepy. And so I always tell families that the first time you give this medication, it can be really helpful to call 911 and make sure that the breathing is not impaired. And then, in terms of rescue medication and seizure treatment, really important to have a written seizure action plan from your neurologist. And this outlines when to give the rescue medication, what to do when the individual is having a seizure. And so here is an example of an action plan. This is from the Epilepsy Foundation. But many neurologists and offices have their own seizure action plans. It's important to keep one at home as well as share one with school or daycare. And next, I want to talk a little bit about anti-seizure medications. And so this table or this chart here, I know that the words are very, very small. I am not expecting anyone to be able to read all of them, but what I want you to take away is that there are a lot of drugs. And a lot of medications that treat seizures. And so here is over time, and this is a little outdated as the last year here is 2020, and just the number of anti-seizure medications. So currently, as of 6 years ago, there was 45 different types of anti-seizure medications. Lots of seizure medications are on the market. And I feel that a couple of them have come out since this paper came out. The goal of anti-seizure medication is to achieve the best seizure control with the fewest side effects. And so, with so many anti-seizure medications, there's certain factors that your child neurologist or your neurologist may use to help decide what medication to start. This includes the types of seizures, if there's a specific epilepsy syndrome, as I mentioned, infantile spasms is a type of epilepsy syndrome that has very specific seizure medications that can be helpful for it. We talked about focal and generalized seizures. Some medications are better from one versus the other. And then before, we had also talked about the slew of different types of seizures, and sometimes specific seizure types can have specific medications that are better. And at the end of the day, it's really about balancing seizure control with the side effects. And it's not unexpected for an individual with frequent seizures to require multiple seizure medications. And as we briefly talked about, not all seizures are created equal. So some individuals can have really difficult to control seizures or can have a lot of seizures. And so in those individuals, it may be really difficult to obtain complete seizure control without excessive side effects. When a person is on multiple seizure medications and are still having frequent seizures, that's what we call drug-resistant epilepsy, right? Multiple medications that are not effective at controlling seizures. In these individuals, some potential treatment options can include epilepsy surgery if there's one or one predominant surgery seizure generating area, then sometimes surgery to remove that area can be helpful. There's devices that can help control seizures. I've listed several here. However, two important points that I want to emphasize. One, when a child is being considered for drug-resistant epilepsy treatment options, it can be really helpful to have a multidisciplinary team, including an epileptologist, a neurosurgeon, as well as potentially a dietitian to evaluate what are the best ways to move forward with treatment options. And then I really want to emphasize this point that not all of these treatment options that I've listed here are effective or ideal for all seizure types. And so if you're ever wondering, why didn't my neurologist consider a DBS? Why didn't my neurologist talk about a VNS? It's likely not that the options weren't considered, but it may be that there is a reason that it's not a good fit for the type of seizures that you have. And so when in doubt, my advice is ask them, why is this not a good option for me or for my child or for my loved one? The last couple of slides as we're wrapping up, I want to talk a little bit about seizure safety. And so seizure safety at home, especially near water, um, my recommendation is always if a child or an adult with seizures is in the water, somebody should be within arm's reach so that if they have a seizure, somebody can take them out of the water. And that person, I always remind my families, it's a one-on-one. They should not be, having watching everybody in the pool. Their job is to make sure, their buddy, if they were to have a seizure, is able to be taken out. Sometimes it can be helpful to have padding or cushioning, sometimes around beds or other active areas if there's a risk of falls during seizure. The other thing that I didn't put on here, but important to keep in mind, is that activities such as riding your bike or climbing a tree for patients that have seizures, it's not that they can't do them, but they need to be safe. So wearing helmets, not climbing higher than, an adult's height. For patients that have drop seizures or the atonic seizures, wearing a helmet can be helpful. Sometimes wearing a helmet at all times, depending on how frequent their seizures are. And as I mentioned, sharing the seizure action plan with school, daycare, caregivers, families, so that everyone's on the same page of what to do if they were to have a seizure. Some common triggers I tried to drop these in while we were talking throughout the talk, but just wanted to put a list here too. These are all things that can bring about seizures or trigger seizures. So fevers and illness, this doesn't mean that every time a child or an individual with epilepsy has a fever, they're going to have a seizure, but oftentimes um, these are stressors for the body. An illness is a stressor for the body, and when this body is stressed, it can decrease this threshold and make seizures more likely to happen. Similarly, disrupted sleeps, not getting enough sleep. Oftentimes, you'll hear the recommendation of sleep deprivation before an EEG because it's more likely for seizures to happen then. Stress or missed medications, as well as dehydration and not having enough nutrition as well. All of those can be common triggers for seizures. And then wanted to put this in here as well as when to update or touch base with your neurologist. Anytime your child or loved one or you have a new seizure type you haven't seen before, your neurologist would want to know a new movement you're worried about. Could this be seizure? Could this not be seizure? If seizures are sort of upticking in frequency or becoming more severe, if you're worried about medication side effects, if you've got question about your medications, your seizure action plan, or your rescue medication, or anytime you're worried about something, let your neurologist know. I wanted to put some resources both for neurologists in terms of what do neurologists do. And so the Child Neurology Foundation has some really great disorder directories that they explain different epilepsy syndromes. And they also have a great explanation of what a neurologist does. They also have a great child neurologist new visit tool that can be really helpful for parents or family members. And then they have an entire epilepsy hub to click around and gain more information. Healthychildren.org is a website that's created by the American Academy of Pediatrics, or the AAP. They have patient, parent friendly summaries on seizures, as well as lots of other neurological symptoms that you can search for, as well as additional links. The Epilepsy Foundation is a phenomenal resource for epilepsy. They have examples of seizure plan. They have recommendation for seizure first aid training and certification. They have some guidance on how to track seizures and lots of information about seizure medications and different seizure types. And then I put the International League Against Epilepsy here. This is a very detailed and a little bit more nitty-gritty diagnostic manual, but for our families and patients that like a lot of details and a lot of knowledge, this can be a great website as well. I would say it is a little bit more, it has a little bit more medical jargon in there, but it has a lot of great information. And so I apologize, I went a little over, but I'm happy to take any questions.
No, no worries at all. Such a great presentation. We appreciate you being here and sharing with us. And also, I love the resources, such great resources. And then for everyone in our audience, if you didn't capture those, I'll make sure to share those with everyone as well afterwards in an email. So as she shared, we're going to move into the questions and answers part. So just a reminder to our audience that you can submit questions in the Q&A button below the webinar player. You can also drop questions into the chat box. Both the webinar player window has an anonymous option. And then if you put it into the chat box, it can come through just to us host and panelists as well. So if you want to do it privately, you can do it that way as well. And one that did come through, it was actually what I think when you were talking about the symptom prevalence, it came through during the presentation was um, when you talked about the seizure prevalence and treatment options. I'm wondering, do we have data on the most common types of seizures seen in this population? And are there particular treatments that seem to be more effective based on those seizure types?
Yeah, Katie, that is a phenomenal question. And I would say a question that we're all really, I would say, interested in that data. But unfortunately, we don't have concrete examples of, which seizure types are more frequent. Um, do the seizure types correlate with some of the imaging abnormalities that we've seen, or a lot of data about which medications are more effective? And so all of those, I think, are wonderful questions, and their motivation for the patient registry and a lot of the natural history studies can help answer those questions and gather those details. And I am cautiously optimistic that with all of the participation and interest from our patients, our families, that we'll have more of that data available, and hopefully I will have a different answer for you a couple of years from now than I do right now.
Thank you for taking the time to answer it. I know we don't have that data right now, but such a great point about the natural history studies, the GFPD patient registry, such great tools right now that are able to collect that data so that one day you will be able to present that information, hopefully, and we'll have that answer. We have another question that has come through. Will muscle tone continue to worsen in a child with epilepsy who doesn't have a paroxysmal disorder? Or if epilepsy is controlled, does that piece stabilize?
Yeah, so that's a really great question. And I would say my answer is sort of in two buckets. One, um, the muscle tone component is, and whether that will change over time depends a little bit on why that low muscle tone is there. So sometimes children can get low, a little bit lower muscle tone and floppier, and adults because of the epilepsy medication. So some medications can loosen your body, and so you can have a slight worsening in tone with some of the epilepsy medications. But oftentimes, aside from that link, the muscle tone and the epilepsy are not necessarily related, in that treating one does not make the other one better or worse, aside from the small caveat of some of the epilepsy medications. And so I expect that as the epilepsy is treated, the patient may be able to do more, and you may be able to see more of some of the changes in the muscle tone. But typically, the treatment for both of those things are different. I hope that answers the question.
I hope so too. I think it did. I hope it did to that whoever submitted that and is listening. We also had one that was submitted beforehand that I wanted to address, and that was they had shared that they have two sons, age 46 and 43. They both have peroxisomal disorder caused by PEX6 mutations. And over the last 2 years, the one has been experiencing clapping hand movement and severe leaning to the right with his torso. Are you familiar with this or have you seen this type of movement? The clapping will last for hours at a time. And both boys, they noted, do have deep brain stimulators inserted in 2009 and 2011.
Yeah, so that's a really great um, question to bring up. I would say one of the things I'm wondering about with the clapping hands is that's a little bit more of a complex movement that I don't typically see with seizures. However, I do see clapping movements or sometimes non-purposeful movements in children with paroxysmal disorders, as well as other complex chil disorders that may have something called stereotypies. And so those are non-purposeful movements, including clapping, sometimes hand wringing, sometimes rubbing your hands together, that can happen, but it's not related to a seizure. The leaning, I don't know from the description if it's related to the hand clapping or if it may just be some change in the muscle tone or contraction or stiffness on one side of the body, including the torso, compared to the other side of the body. So whether it's more of a muscular change, especially if it's a consistent lean or something that doesn't come and go, that makes me want to think a little bit more about the spinal cord and the spinal column and see if there's been some change in scoliosis or misalignment that might be happening with the lean. Those are the two things that I think about. I would say, based on the description, it doesn't sound like a seizure, but maybe some other of the symptoms that we talked about.
Thank you so much for taking time to answer that question that was submitted. And I immediately was thinking of the great advice, and I know myself and so many other caregivers record and take the recordings in or email the recordings to the neurologist and approach it in that way too. So if that hasn't been done to the person who submitted that, that could be a great way of starting that discussion with your neurologist. We have another question. Is ataxia and seizures linked to each other?
Typically, I don't think of them as linked to each other, in that they can they have sort of different treatment options for both of those, but both of them can occur because there's been some injury or some change in the brain itself. And so they're both neurological symptoms, but one does not necessarily mean that you're going to have the other.
Thank you. And another one, actually, when you just mentioned the scoliosis, they submitted a question and just wanted to know, do you often see epilepsy and scoliosis in children together?
You definitely can. I would say that you can also see them independently. So children can have scoliosis without having epilepsy. You can also see children with epilepsy that have scoliosis. Typically, I think of the scoliosis more related to how loose or tight different muscles in the body are. That's usually something that goes a little bit closer together or closer hand in hand.
Thank you so much. We also have a question about the treatment options, and I actually relate to this question a little bit because I remember many years ago, my own son, we didn't realize until another parent told us that there was a easier method to administer a rescue med. So, how the question is, how do neurologists stay up to date on new treatment options as they come available?
Yeah, that's a fantastic question. And I would say many neurologists attend our national meetings where we hear a lot of the new updates on treatment management, and management of different symptoms. Just like you all have this wonderful community, lots of neurologists also have, communities where we say, oh, we have this patient, we've tried X, Y, and Z treatment, and sort of seek the advice of our colleagues that may have a little bit more experience or may have a special expertise, for example, in neuromodulation. And so all of that together helps us stay as update as we can be with the new changes. And the last thing I'll say is many of our national societies, like the Child Neurology Society, the American Academy of Neurologists, or AAN, publish guidelines. And so, like the Peroxisomal Disorder guidelines and scientific literature that comes out, we also have literature that just summarizes a lot of the new developments or new ways that that's recommended we manage different conditions. So lots of different ways to stay updated.
That is great news. Thank you so much for sharing that with all of us. We have another one that came through in the chat about their grandson who has Zellweger spectrum and disorder, and he is 9 months old. He has eye deviation, lip smacking, some limb jerking periodically, but never seems to be in any distress. Has not been diagnosed as having seizures. However, he does not have a neurologist on his team, and this has not been reported to his general pediatrician. Does this sound like he might be having seizures?
I think that given the description, it seems like this might be a great time to take a video the next time he has these movements and send it to the pediatrician. Usually, many of our pediatricians are phenomenal at, raising the red flags that this could be a seizure, or they may have some other ideas of what these movements could be. And they may be able to help facilitate getting your grandson to a neurologist. But I would say the first place to start is to try to take a video and share it with your pediatrician. And at the very least, let them know that these are movements that you're seeing.
And they said, excellent, thank you so much. And there is a little bit of a part two now question that I think that's going to piggyback off of that about if you have a paroxysmal disorder and you're not having diagnosed seizures yet, should you still request referral to see a neurologist?
Yeah, I think that's a great point, and I think that's a great segue to part two, that we as neurologists manage quite a variety of different symptoms, not just seizures. And so, oftentimes, I would say seeing a neurologist at least once so that you can get a great baseline exam. And they may be able to say, oh, these are other neurological symptoms that we can help with. So sometimes there can be subtle symptoms that are there that might benefit from a neurologist's guidance. So I would say yes.
Thank you. And that is a perfect segue. If you want to go ahead and go to the next
Yes,
slide, I want to just
definitely.
thank you, and our audience again for submitting such great questions and you taking the time to answer them. We do want to share about the part two of this series happening on April 16th, where we are going to explore neurology beyond the brain. That this next session will provide a deeper dive into how the neurological system can impact the whole body, including muscle tone, mobility, motor function, bladder and bowel function, and more. Um, and if you can go ahead and move to the next slide. I just again want to thank you, Dr. Shrivastava, for being here, helping us understand this very complex yet very important topic of neurology. Just looking forward to learning from you again on April 16th. To our audience, the QR code on the left side of the screen will take you to a webpage where you can learn more and get involved in the GFPD patient registry for peroxisomal disorders. You heard us talking about that actually a little while ago. The QR code on the right side of your screen is where you can sign up for the GFPD Top 3 newsletter to receive bi-weekly updates, which include information about events that you are attending right now, research opportunities, community updates, and more. We also encourage you to make sure you're following us on all of the social media platforms to stay connected. Please also keep an eye out for our short post webinar. Hopefully, when you exit out of this in just a moment, you're going to have a survey pop up. If you could take a moment to complete that, your feedback is incredibly important to us and it helps shape future programs like this. Thank you again, everyone. Thank you, Dr. Shrivastava, for being here. We hope everyone has a wonderful rest of your day or evening, depending on where you are joining us from. Lots of thank yous coming in. Um, Said it was a fabulous presentation. This was
Great.
great. So thank you again, and good night, everyone.